I would like to, first of all, thank Angela Deal. Angela is a medical illustrator located in Austin. She used to be on faculty at the UT Southwestern Medical School in Dallas. She actually drew this illustration. So this is something that we will be using. And as you can see here, this is a case that I'm going to use for discussion. So instead of putting a title, I thought that why not, when we are chit-chatting for the 10-15 minutes before the session starts, put the case up there with the image of the polyp that we're going to discuss so that people can think about it. Angela, thank you so much. All right. So I would like to again thank the panel, Sylvie, Roy, Sylvia, and Sriram is on call. He said that he will join. I think he's on call.
I think he's on the call.
So Sriram, you're welcome to comment. And I would like to again thank my mentor, John Stroline, Mr. Charles Butt for their grant support. And special thanks to Angela for creating beautiful illustrations, and my institution at the University of Texas, MD Anderson Cancer Center. So as you can see here, there's a lot of talk about colon cancer screening, whether we should we should start screening a little bit earlier than 50 years, whether we should start at 40, 45. And so here is a case. This is actually, the way we put it is, this patient is waiting to be taken into the room. He's a 40-year-old man, and he underwent a colonoscopy. The reason why he underwent colonoscopy was he was passing mucus in the stool, but no bleeding, no weight loss. And his PCP referred him for colonoscopy, and he underwent a colonoscopy at an outside facility. And they found a cecal polyp. So as you can see here, the cecal polyp is on the image on the computer screen there. And he was otherwise in good health, no past medical or surgical history or family history of cancer, not on any medications, except that he's been smoking for 20 years, 1 to 1.5 packs of cigarettes, and doesn't drink any alcohol. All right, Sylvie, you want to pick your favorite nurse or your nurses to talk about other techs? How do they plan to take care of this patient from pre-op to procedure to recovery?
Okay, so we have some of our endoscopy nurses on the Zoom call. Of course, there could be other nurses, and if I don't know who you are, please feel free to unmute yourself and chime in, or you can also put your comments in the chat box, and I'll keep an eye on that. So we have, and there's no pressure, there's no right or wrong answer. We're all here to learn. So we welcome any comments any of our nurses have. I know Edith, Joanne, Stephanie, Jung, Kala are the nurses that I see. So what do you guys think? And this can be a group effort, so there's no pressure on one person. If you have this patient in pre-op, what are some of the things that you are thinking about planning, making sure you have in the room before you take the patient back to the procedure room? And not necessarily, I mean, let's assume that we already have, you've checked the consent and the armband and all of that type of stuff. The pre-op evaluation has been done. So in terms of the procedure itself, what kind of things do you want to do? Who do you want to talk to?
I guess this is Stephanie. Hi. So hi. I think a lot of this stuff is already going to be in our room, but things that we would try to stalk to make sure are there are Irby or electrocautery unit, injector needles, anything that we would use to lift on the whatever the doctor's preference is. Of course, our grounding pads, and during pre-op, being sure that we ask the patient if any metal in the body, you know, just continuing to check pre-op and make sure all those questions are answered appropriately. That's some of my initial input. Anybody else?
Anybody else? How about medications that the patient's on? What are some of the things, especially if you know that there's this cecal polyp for resection that's on the screen right? What are some of the medication concerns that you may have when you're talking to the patient?
This is Joanne. We would want to make sure that if they're on any blood thinners that they held them.
Okay. And how about, so for at MD Anderson, we have patients who come in from other locations. So are we concerned at all about where the patient lives and what their travel plans are?
Yes, a lot of patients will sometimes decide to stay overnight
Okay.
just for you know, not at the hospital, but a local hotel, so they're close by if anything happens.
Okay.
Right, especially being the location, I think we said was in the Cecal, so you know he's a little bit more high risk for removal of this. So I'm sure Dr. Raju, if he were, or any of our doctors were removing this, they'd want him to stay close by for a day or two.
Okay. Does anyone else have any other comments?
Yeah, another quick point is to look at the BMI of the patient, and sometimes if the patient is very obese, I would like to have in the room an abdominal binder. Sometimes it helps to stabilize the scope position and ability to intubate and stay stable. Thank you.
That's a wonderful point. So in terms of talking to, since Dr. Parapudi mentioned intubation, is this something that we want to talk to anesthesia about? Do we feel like this is going to be well, I guess it depends on who's doing the procedure, but is this going to be a prolonged procedure? Is this going to be a quick in and out? What are our thoughts in terms of communication and discussing with anesthesia? What are some of the things that we would want to talk to them about?
Just a clarification, I apologize. When I said intubation, my point was cecal intubation, but
Oh,
your
I see.
point is right. We also need to think about the general anesthesia.
Right.
All right.
What do people think in terms of talking to anesthesia? So this is likely going to be a prolonged case, and we want the patient to be stabilized. At one of our previous Zoom classes, Raju had said that he likes to have these patients intubated, general anesthesia, so that there is less abdominal movement, especially if the patient's obese. Generally, you can have a lot of abdominal movement, and that means colon movement. And so that's you know, that's like doing a large EMR on a rowboat. So you're just kind of bobbing back and forth, and you don't want necessarily to do that. It's not the safest technique. So intubation and stabilization of the patient during the course of the procedure, I think, is an appropriate thing.
I would prefer to have him on a propofol program because we use conscious sedation for colonoscopy. But in this case, because it's quite a large lesion, and I assume that it may take a little bit more than the regular colonoscopy, I would prefer, and stable conditions, I would prefer to have him on the propofol program.
Okay.
Good, excellent point. Go ahead, Raju, if you want.
Any text there?
I didn't recognize any of our people, but there certainly could be text on here. They will have to let me know.
Comment? All right. Okay. I don't know whether we have any of our fellows. If anybody, any of our trainees or any trainee out there wants to look at this thing, and I want to see how do they put their report, because that report is really critical. Especially if you want to refer the patient to someone else.
Which report, Raju? How
In
do
the
you?
endoscopy report, right? Once you see this, say for example, you see this thing.
Oh, I see.
and you decide to say, okay, I'm not going to cut this polyp, I need to send it to somebody.
Uh-huh.
You want to put
How would you
certain
describe it?
details
How to
about
describe?
this lesion,
Right.
especially any cecal lesion. What
Uh-huh.
are the things that you want to put it into the report,
Can we ask maybe Dr. Joseph Zong? He's not a fellow anymore, definitely. He's faculty, but how he would describe this lesion. Joseph, do you want to give some comments?
Or maybe Ravi is there from Singapore.
Oh, okay.
Ravi, you want to comment? Ravi is not in training. He's finished his training. He's on faculty in Singapore.
So I assume I will describe the lesions based on the Paris classification.
Mhm.
Like in this case, this is a sessile lesion. Looking at it, so I'll describe it as a sessile lesion based on the size. Say how close it is to the appendix. Then I would describe about what are the other features which I look to suggest whether there is any submucosally invasive disease. So I would describe the NBI pattern with near focus. Then if there is any fold convergence, I will look at the fold convergence and I will describe that. And based on the image, I couldn't see any fold convergence here. And yeah, so additionally, what I would describe is whether this lesion lifts. So in essence, my report will consist of the morphological appearance of the lesion and imaging appearance of presence or absence of submucosally invasive disease. And I will describe what type of polyp it is, whether it is TA, TVA, and then I will explain about presence or absence of additional features which support the diagnosis of submucosally invasive disease.
That's great. Wonderful.
That's good. I think
One of
Joseph
the-
wanted. Sorry.
Yes.
Everyone?
Yeah, Joseph wanted to comment. I think he muted himself and was talking into the muted line. And Joseph, you want to comment? Yeah.
Sure. Yeah. Actually, that was spot on. I was just going to say that making sure that we know what the features of this polyp is a pedunculated, is a laterally spreading tumor, as those would influence the strategies for resection.
Great point.
May I make a comment, Raju?
Yeah, please.
Yes. I would also mention the relation with the appendiceal orifice. If I interpret this image correctly, I think the polyp is located at about between 12 and 3 o'clock of the appendiceal orifice. Am I right?
Yeah.
And it doesn't seem to be fixed. I mean, it is adjacent to the orifice, but doesn't involve the orifice, which is good. I mean, that would make our resection a bit easier. I hope that it will be possible to lift the polyp entirely. So, and with regard to the macroscopic appearance, I may need some help from Roy, but I think that our Japanese colleagues describe early cancers with this appearance. They call them Buddha-like appearance because it's a rounded appearance. In fact, it's a sessile lesion with irregular surface, which may reflect a high risk of submucosal invasion. Roy, do you agree?
Roy has a little bit of a problem with his voice, so.
Okay.
Yeah.
Okay.
So
that is, such lesions may have an increased risk of submucosal invasion. That was my point.
All right, that's
so
good.
We have, it's again a reason to resect them en bloc.
Yeah.
So one thing, Raju, oh, sorry, go ahead.
Go ahead, please.
No, I think one thing that we're not very good at as endoscopists, and there's been papers published on this, is estimating the size of the lesion. So I agree with everything that's been said, but I would like to know how they would estimate the size of this lesion, because it is important. I mean, we can say one thing, and then when the patient goes for an EMR or ESD, hopefully, as the ESD would be en bloc, but EMR en bloc, resection, they take it out and then they put a ruler and then they take a picture, and it's always different from what the initial estimation was. So maybe can I get some guidance from our experts in terms of how they would estimate the size of this lesion? Because I think it's important also to let the referring gastroenterologist know that.
All right, let's see what Sylvia thinks, what
If I look-
Robbie thinks. What's the size? What do you think is the size of this polyp?
I think that that's a very good question. We are never very good in estimating the size macroscopically, but I think when I look to the lumen, I see that it's about 1/3 of the diameter. So that could be something like 2 centimeter max. So
Okay, that's a reasonable way of
That's
looking at it.
about 2 centimeters max, 1.5 2 centimeter. But let's listen to other points.
Okay, Robbie, what do you think?
I agree with what Sylvia said. It's roughly around 2 centimeters. One way of assessing it is using a snare, and then we can open it around to actually see whether the diameter of the snare and the polyp size is similar. So that might help. Typically, a 20 millimeter snare should help.
Okay. I think I'm glad that we covered a lot of important points. When you describe a polyp, we describe the size, we describe the location, we describe the Paris classification, we describe whether there are features of invasive cancer or not, like Ravi commented. So those are all the things we want to describe. But one thing that is important in the CCAM, which is, Sylvia brought out, is the lesion extending into the appendix or not? And if it is going into the appendix and you can't see the distal edge into the appendix, then that's a patient probably needs surgery. And you can decide, well, how you're going to do the surgery, whether you send the patient directly to surgery, or whether you resect what you can and then let the surgeon do a cecal-based resection. There are different ways of looking at it. But that's very important to comment when you're referring the patient to another center where they're going to do resection. If it is going deep into the appendix, you cannot tell the patient that you are going to get a curative resection. Although there are people who have tried to invert the appendix and do the cutting, and that is beyond the scope of most advanced endoscopists. It's only good for a few cases where people try to show that it is possible, but majority of the time it is not possible. So comment on whether it extends into the appendix or not, keep it in mind, and also comment on whether if you cannot take a photograph to show the whole lesion, comment on whether it goes to the ileocecal valve or not. So you should say some negative points: no involvement of appendix, no involvement of the ileocecal valve in your report, and that helps. When I saw this patient with the endoscopy image, this image is, I took it, but the image that came from the referring gastroenterologist was a little bit blurry. So all I saw was a large cecal lesion, and I could not figure out whether it was extending into the appendix. So I told the patient, if it were going into the appendix, I may not be able to cut. And it's important to educate the patient about that before you go in to do a procedure. So that's one important point that I want to make here. All right.
May I ask a short question to Professor Raju? Given the location, given the a little bit unusual macroscopic appearance and yellowish aspect, would you consider a carcinoid in the differential diagnosis?
The thing is, Sylvia, what's happening is this is just a stable one image, right? And when you, although there is yellowish, I have actually seen only a couple of times where carcinoid cells mixed with a villus adenoma in the submucosa. I'm glad that you bring that point of being yellow, but this was a picture that was taken from the video, right? As the video was running, I captured an image, and then you still have some stool sticking there. That's why that yellow appearance.
I fully agree.
Right.
Thank you.
Right.
Thank you.
All right. So, the thing is, we are thinking about this is a large lesion in the cecal base and go close to the appendix. The question that we have is it going into the appendix or not? And how do we evaluate? And as you can see here, at the end of my scope, there is a cap. It's a good idea to put a cap for your colonoscopy exams as well as for EMR. So let me show you what we did. So we went underneath the polyp. As you can see, the cap will allow you to push it around. Now you can define the opening of the appendix. And I made it a point to always examine the appendix close by almost kissing the appendix and documenting that the appendix opening looks clean. And in this case, this is not a sessile polyp. Actually, this is a pedunculated polyp. It is a short pedicle, but it actually flattened, right? That's the reason why it gave that appearance that this was a sessile lesion. So once you see that this lesion is got pedicle, it's much easier to resect. You have less risk of large resection, less risk of worrying about a perforation, because if you have a pedicle, you have the safety margin. So we decided to inject. As you can see, we're injecting saline with indigo carmine and a little bit of 1 in 10,000 epinephrine combined. And what I try to do is I try to inject at one point and change the direction of my needle so that I get a big injection at one point. I don't want to inject multiple points, especially with saline, because I'm worried that I may not have a good lift. As you can see here, we got a nice lift, and I thought that we should inject a little more to get a little more margin. So typically, in this case, I probably may have injected 20, 25 cc's to get a nice lift. We basically injected a large amount in the first injection. So what my nurses do is they have their syringes filled up and they're ready to be injected. Typically when you see a case like this, it's best to have at least 40 cc's of saline with a little bit of methylene blue in different syringes, or you can take a 50 cc or 100 cc saline bag and then mix the solution there and then draw it fast to help the technician or the nurse injecting so that you don't pull the needle out and continue to inject large amounts in one session. All right. So any comments on how do you inject? Sylvia, what are your choices? Ravi, what are your choices? Selvi, here I injected saline. That's what I do for all my cases. Although there are different solutions that are available, either Eleview, Orize, Hitostarch. My preference has been to just use saline.
I use gelfusin and indigo carmine. It's like 40 cc of gelfusin with 8 to 10 drops of indigo carmine. And in terms of injection, I follow the dynamic submucosal injection technique, which Roy used to teach me while he was in Singapore. Yeah, so that would be my preference.
Okay, that's good.
I would use saline and indigo carmine as well. And I have learned the same technique from Roy, the dynamic injection. So for the rest, the same steps.
Okay. Selvi, what do you do?
I do the same, Raju, but I would just say that you want to make sure that you're injecting all around the perimeter of the lesion. And I know I've learned from you, Raju, that to take pictures to show that there's adequate lift on the perimeter of the lesion all the way around.
Okay. Then next is how are you going to cut this polyp? Let me ask people, what are their choices? Snare type, snare size, and electrosurgery settings. Okay, we'll go one after the other. Selvi, what is your snare size, snare type, and electrosurgery setting?
So I would do probably either a 20 or 25 millimeter snare, hot snare. And Raju, I have the luxury of cheating. I use your settings on the Herbie machine. I look over to make sure that, it says Dr. Raju Polyp, and then I feel comfortable cutting.
Okay.
There is a question about injecting into the head of the polyp itself. Dr. Sammy's asking, so we should address that at some point.
Okay. Okay. Let me hear what the other people's choices are, and then we'll answer Sammy's question. Yeah.
So I use a spiral snare, probably 20-25 millimeters. And then the setting will be effect 2, cut interval 3, cut duration 3, 2, 3, 3.
Okay. All right. All right. And Sylvia?
I would use hot snare and 20-25 millimeters. And I will use Endoscopy Q, the settings which I never change, 314, 315.
Okay, that's good. All right. So regarding the injection to the head, I think you could inject into the head. You're probably not going to cause much problem. When I see a polyp like this, where I could, there's a very little short stalk. For some reason, I thought that, okay, I got a good lift. Let me move on and do this snare resection. The only literature that's available on injecting into the head and into the stalk is when you think about epinephrine volume reduction, where you inject epi into the head and then into the stalk and give time. Typically a sigmoid colon polyp that is too large, like we talked about. And after the injection, you go up to the cecum. And then when you come back, the polyp would reduce in size. When you have a lesion like this, could you use the same principle? Probably. But we decided to just go with the stalk and move on. So in this one, I used a 20 millimeter snare, a stiff snare. And my current settings are Endocut Q31. Usually my current settings are Endocut Q313. That's for most lesions, 10 millimeter to 15 millimeter. When I see a big lesion and I worry about bleeding, I try to increase the interval. Instead of 313, 3 is the interval. That is about 700 to 750 microseconds. I go up to at least 1 second, either 315 or 316. At the same time, when I increase the interval, I do worry about deep thermal injury, especially in the cecum, and possibility of delayed thermal injury related issues. So you're worried about bleeding versus delayed perforation. It's always better to have a bleed because you can control the bleed with all the devices that you have. What you cannot do is if the wall, the cecum falls apart later on, the patient will require surgery. So here is a large snare.
Allô, ça va? Allô? Oui, c'est what it's meaning.
Sorry, Dr. Weil, can you mute yourself, please, unless you have a question? And Imad, I see that you're also unmuted. Please mute yourself, unless you have a question. Thank you.
So here is a large snare, and we are able to get over it completely. So for the sake of trainees who want to do large polyp resection, the most important principle is to be able to reach the cecum with a relatively short straight scope, between 60 to 70 centimeters to the cecum. If you practice that every time you do a colonoscopy, you will be able to make these very small movements, controlled movements, to be able to do resections. All right, so we got the cut, and this is what's happened. So Sylvia, how are you going to manage this bleeding?
I think washing to make sure that I have a better, as good as possible, I can visualize and the origin of the bleeding if possible.
Yeah, you can see that.
Yes, and I think the severity of the bleeding and the magnitude of the bleeding says that I can't wait a lot of time with inspection. I have to take a decision. And I think in this case, because I don't see anything which could be locally treated, I would prefer to use clips and to clip as fast as possible.
Okay. What is your preference of the clip? You know, now there are so many different clips in the market. Any particular preference? You have clips from Olympus, you have clips from Boston Scientific, clips from Olympus, clips from Boston Scientific, clips from Cook, clips from Microtech.
I use the Boston clips more often. I have seen and just a few times used the Olympus clips, but I have more experience with the Boston clips.
So, Selvi, what do you do?
So I think clipping is certainly, I mean, we have a lot of options, as you said. So clipping is certainly one thing that you can do. I would want to, so one technique that we've discussed here on the Zoom classes is just because you use a clip doesn't mean you have to deploy the clip. So you can use that as a hemostatic maneuver. I would be hesitant to deploy clips without being able to actually see inspect the edges of the lesion to make sure that the resection is complete. I mean, it looks complete, but I would want to be able to take my time and not be pressured by having to stop the bleeding. So you can use a clip as just as a hemostatic maneuver. You can use a hemostatic forceps. You can use APC also. That can help. So those are some of the things that those are some of the tools at our disposal.
So we decided.
And then of course, yeah. Also, obviously, I think the soft tip, if one of the co-hosts, because I'm not a co-host on this for some reason, they can go and try to mute the people that are talking. That would be great.
I'll do it.
Thank you. I would do it, but I don't seem, I'm not a co-host on this one, I think. So, and then the soft tip coagulation is another option.
Yeah. So a couple of things that one needs to keep in mind is this. Whenever you're trying to do a large polyp resection, first thing is the nurse and the tech and the team should be talking about it and have all the equipment in the room. I'll tell you that. It's very important to make sure you have all the equipment in the room. And I want to share one anecdotal case. I asked for a hemostatic forceps, and we had the hemostatic forceps, and we opened it, and then we went down the colonoscope, but the hemostatic forceps was too short. It was an EGD type of hemostatic forceps. So you don't want to then get stuck, right? So something to keep in mind. So here we use the hemostatic forceps and we're able to control the bleeding from below. And as you can see here, there was also bleeding coming from the upper edge as well. So when you have a large polyp, we talked about it before, with a thick stalk, they tend to have multiple feeding vessels. And as you can see, the bleeding from below stopped, but there is bleeding coming from the upper edge. And once the vessel gets stuck, it tends to retract under the edge. And you may find it difficult to control the bleeding. You know, I was not able to see. I was doing a little bit of a blind assessment and say, okay, maybe that's where the bleeding is coming from. And then trying to see if I can actually get that and control the bleeding, as you can see here. So if you try once or twice and you don't control the bleeding, you have to think about some other measure rather than trying to go through the same steps again and again. All right. So now, like Sylvia commented on, we decided to use a clip. And whenever I have a problem like a big bleed like this, I would like to pick up a clip with a bigger blades, you know. In this case, we ended up using a Cook clip. And as you can see, when I applied the blade on top, the bleeding stopped. Did you guys notice that? Right, let me go back. I think it's a very important point to learn. Just a mechanical tamponade from the blade pressing on top of that edge stopped the bleeding. So by doing that, you appreciate that you are at the right point, right? You see this when I press it down and then put water, there's no more bleeding, right? That means I'm at the right point. And that's the time when you can actually close. In this case, because it was a subpedunculated polyp and our snare was below the head of the polyp, and as you can see from the resection edge, we did not have any residual polyp. We decided to apply the clip. And if in case there is any doubt, you could sit there, close the clip, don't deploy, wait for about 5 minutes for mechanical hemostasis and a clot to form, and then reopen the clip, clean out the edges, and then deploy the clip. So as you can see here, the other thing is when you're applying the clip, you want to have both blades on either side of the defect, you know, so that the legs are on either side, as if you're getting on a horse. You don't want to have one blade short on one side and the other blade long on the other side. What will happen is the blades will move and then it will lose grip on the other side, and your clip may not be effective. And the other thing is you will notice that there is little or no space in between the two blades of the clip. One thing that is important is of all the clips that are available out there, probably the best clip in terms of ability to rotate to whatever degree you want is the Boston Scientific clip when you want to rotate. And when you are in a rush and you want to have a very quick action and you want to have a very fine control of your clip blades, I think Boston engineers have done a fantastic job in designing a beautiful clip. In terms of the blade width, the Cook guys have a little bit of a bigger blade width. So something to keep in mind, you know. Once you control the blade, after that, you can decide whichever clip you want to use to close the defect. So the most important thing is keep in mind that large defects have multiple feeding vessels. And there is a study from Spain, beautiful study from Spain, where they have shown that when you close a defect and you close it completely, your risk of delayed bleeding is reduced compared to partial closure. So it's important to close the defects completely wherever it is possible to do so. And that's the reason why we are trying to completely close the defect. And after closure, you want to take a photograph on either side, showing that your clips have actually approximated both edges of the defect nicely. So you want to take a photograph on the top side, showing the clips, showing the mucosa on the top side, and also on the bottom side. So that is something to keep in mind. So here is a large polyp that we were able to cut. We were prepared for the bleeding, and we were able to close the defect. So one thing that is important is the teamwork, right? The assistant is helping you with the clip, and the nurse on the is helping you open, pull out the clips from the containers or the envelopes, and make sure that the clip is straightened. When I say the clip comes in a loop, right? You want to take off the loops and hand it over to the assistant in a U shape, so that the assistant could actually give it to the physician, and the things go smoothly. So those are the things that are very important to come to keep in mind. So any comments?
Roger,
Yeah.
comments to get us started. I liked how there was a very short distance between the cap on the end of the scope
Yes.
and where you were actually working. It was a very short working distance. So I like that. I like the amount of pressure that you put when the clip was across the lesion, about to get on the horse, as you said, and you put that pressure and really push down. And when you showed pictures of after the clips had been deployed, these were not cosmetic clips placed for cosmetic reasons, as you said on one of your previous Zoom sessions, and I remember that. There's not a lot of space. It's grasped a lot of mucosa. It's grasped a lot of real estate, and it's very efficient and more effective that way. So those are just some of the comments that I had. And I see that you've also placed a couple of different types of clips.
Right. That's
So
right.
that emphasizes that you kind of use what you need for that purpose at the time.
Right. Yeah. You know, the
Maybe-
most,
What it helps in most of the cases, because you have to close a quite large wound, just deflate the colon a bit before placing the clip to make sure that you better close the defect.
that's a very good point, Sylvia. And I want to make it a point here. I want to share something that is important to share, but I do not want you guys to do this now in the midst of the COVID. You don't want to get any aerosol into the room. What I used to do before deciding to resect a polyp or whatever, so you can decompress the colon by suctioning, by applying, pressing on your suction button and taking off the air. That's one way. And when you do that, what happens is the column of air in front of your scope actually gets decompressed, you know. But if you want to decompress the colon for larger segments, what I do is I take off the biopsy port cap off, and basically the channel is open to the air, and if the colon is under a lot of pressure from air distension or CO2 distension, by taking off the biopsy port off, it vents the air off, and the colon actually decompresses very nicely. It helps you to do the resection, and it also helps you to apply clips by reducing the size of the defect when the colon decompresses. And
Thank you. That helps a lot. Yes.
right. And the other thing is I also do, which is important to share, is sometimes the defect is too large and you are trying to close and you're having a difficulty that the other edge doesn't come into the clip. And in that case, if you suction, you can't see anything because the whole colon collapses. And when I'm applying the clip and I cannot get my blade from the top blade onto the other side of the defect, then what I've done is I pull my biopsy port off a little bit to allow escape of air from the biopsy channel gently so that the colon decompresses slowly, and then I apply the clip. I've done that, and it helps. It helps to keep in mind. All right.
Thanks a lot.
Right. So there are a couple of questions. One is from Maria, soft coagulation. Soft coagulation, I can use it with a snare tip, but snare tip soft coagulation, when you have a vessel like this and bleeding actively, that is probably not going to really work. It's usually for smaller amount of wounds. When you have a brisk bleed, it is best to have a hemostatic forceps because it can apply some tamponade and you know that you stop the bleeding before you coagulate. And in terms of the settings, soft coagulation the settings, I typically use 4 or 5 effect. I try to use 80 watts. And Whale asked about injection of the base of the polyp if it bleeds. I think that's another option that one could try. Maria said, try to coagulate with the tip of the snare and then place hemoclips. I agree. That's what we have done. Sriram asked, what circumstances would you think of endoloop? In this case, I would not consider putting endoloop up front. But once I put the clips, and if you're still worried about it and you want to play safe, because you created a pseudo stock with the extension with the clips, you could apply a loop that people have described. And Sammy asked, what about underwater in the cecum? You could do that. The only thing is, my experience has been with injecting fluid. I feel safer that way. So whatever works, as long as you can refine your technique, that it actually works. You could try and do underwater also. But by injecting fluid in the cecum, you tend to have a little bit of a safety margin. That's that's just been my practice. So the other thing is, when this patient had quite a bit of bleeding, right? And one thing that I would suggest is to take time and go to the segment into the ascending colon or transverse colon and clean off the blood, clean off all the mess, I put it that way. The reason I do that is if you don't clean out and then come out and the patient goes home and the first bowel movement has some dark material, you'll get a phone call, right? You don't want those phone calls, right? So I make sure that I clean out all the blood so that that issue of questionable bleed would not be something that would be bothering us. So in terms of taking in this case, you don't need to put a tattoo because it's on the cecum. And you could use, as you can see here, I want to show you something here.
Nice 3 blood point.
Right, big blood vessels, 1 second.
Beautiful blood vessels.
So there's 1 blood vessel here, 1 blood vessel here, 1 blood vessel here, 1 blood vessel here. So big blood vessels.
Wow.
So when you have a polyp that has a lot of meat, you should worry about bleeding. So you should be prepared for that bleeding. So something to keep in mind. If you have a big polyp, big juicy polyp, the concern would be bleeding, and you should be prepared about that.
So Raju,
go ahead.
Seeing this, when in retrospect, you said that when in your injectate that you put some epinephrine. Would you, looking at this now in retrospect, would you have put more? Should you have put more epinephrine?
I think the thing is, one thing is, probably not going to make that much of a difference, right? After
Okay.
that, one thing is we should, whenever we have a bleed, one thing we should keep in mind, one aspect of snare resection that is more of an art is how do you close the snare while cooking the blood vessels and achieving hemostasis and cutting the polyp without deep thermal injury. That's an art. I've not perfected it. That's why you can see the bleeding. And mentally, I'm prepared to have a bleed rather than a delayed perforation, right? And if you can actually plan for that, that's fine. And even now, I've been trying, okay, can I close slowly? And I think probably last year, I was worried about a patient with von Willebrand disease, diabetes, hypertension, and Jehovah's Witness, bleed. And I closed so slowly that it was a beautiful cut, but the deep thermal injury led to delayed perforation. So, how do you refine that art is, I've not yet reached that stage where I can say, okay, I can have a very good cut with no bleeding. So whoever does that, one should salute them. All right. So the other thing is I want to share with you, when you are going up into the cecum, you have to keep in mind whether the sigmoid colon is narrow, angulated, fixed, twisted, or whatever. That is something to keep in mind, because when you resect a polyp and you are going to bring that polyp out and you bring it with a Roth net or something like that, then if you have an angulated fixed sigmoid colon, then what happens is you may get entrapped, like the basket entrapment of ERCP scope. This could happen in the colon. I have not seen a report, but I've seen a large gastric polyp resected, and when they were pulling it out from the GE junction, they actually ended up with an esophageal perforation.
Wow.
So I've actually seen that case, and then because of that, you can see that I'm using a clip to pull this thing out, hoping that if it gets stuck somewhere, I can reopen the clip, let it go, then cut the polyp with a snare and bring it out. So that's the reason why you're seeing a clip being used here. All right. I think we can open it for comments.
There's a couple of comments in the chat.
So Bernard talks about any thoughts of using IT knife in dissecting the polyp. You could do that. To be honest with you, I've not had, I don't have experience in doing ESD, although I've tried my best to learn, but I felt that majority of the polyps that we see in the United States, 90–95% of the polyps can be managed with a snare, even 95+% of cases, I think ESD knife is probably useful, I think, but it will take a much longer time to do the resection. And pathology, it came back as a tubulovillous adenoma. One thing that I'm seeing is I'm not seeing what the Australians reported in terms of big polyp having more cancer. For some reason, I'm not seeing that. The number of times where we resected and the polyp showed cancer, large polyps, was about less than 5%, Sriram said, comment and show different caps you use or recommend and demonstrate how it is deployed on the scope in the future sessions. I think we'll set it up. I'll ask my team. We will shoot a video about how to put a cap at the end of the scope for next time.
Raju, you have a, that reminds me, you did a video of that and uploaded it to YouTube, I think.
Right.
Do you remember? It was much earlier on.
Right.
Let me try to find it.
All right. So Roy commented about the classification. I think this polyp, if I read it right, I think it looked, the height is more than the width. It is, but it also got a little bit of a stalk. It is, the stalk is short. It is probably a 1SP. You know, if you want to put it as 1P, you're not going to be wrong. It is not a 1S. It looked like a 1S when we started, but by going underneath and looking at the fold that flopped onto the top of the appendix, it made it look like a sessile polyp. Sylvie is actually putting a video link to how to put a cap on the scope. All right, any other questions? Any comments? Sylvia?
Thank you. Very, very instructive case.
Thank you. Thank you for all the discussion. I think input from you and other panelists makes it interesting. And
So can we, thanks to our nurses that participated, Stephanie had a question about any comments in closing that we would give to the patient at the time of discharge, perhaps in terms of
why don't we ask
using
Stephanie to
blood
tell
thinner.
us what she does?
Okay, okay, Stephanie, here you go. What would you do, Stephanie, if you were in the room with Raju and he had done this polypectomy? What kind of things would you tell the recovery room nurse?
I was hesitant to put that in the chat because I knew I would be called.
You would get, yes, I was trying to save you, but that was not gonna, yeah.
I know, like Joanne,
That's okay.
come on, save me.
Yeah.
So obviously at our institution, we have kind of that standard Dr. Raju EMR diet. So I would expect he'll have special diet instructions. And I was just kind of wondering what other institutions use, what other physicians prefer to use for diet instruction for these patients. And then also our, instructions for post-operative bleeding precautions and staying nearby, and also medications to avoid for this patient.
Right.
So that was my
I think those are all
thoughts,
excellent
and
points.
I wanted feedback from everyone else on what other institutions and physicians prescribe.
Let's ask Sylvia and let's ask Ravi.
Yep.
I think we would instruct the patient about the risk of bleeding, and we will advise not to travel far away in the next 2-3 days. And this patient didn't use anticoagulant therapy, which makes things easier. If this was the case, then there is a certain department, a special department, which arranges, which makes appointments with the patient when to restart medication. And if they are uncertain, they call the gastroenterologist to make sure that they can restart medication. For example, if they still had some have seen some red blood in the stool and are worried whether or not to come back to the hospital, they will always call us.
It might be nice to be proactive and also touch base with the patient in a couple of days. Let them see how they're doing. That would be my comment. Go ahead, Ravi.
Yeah, exactly. What we do is we do all what Sylvia mentioned. In addition, we just give a call to the patient the next day to actually find out how they are doing. In Singapore, it's quite easy because the island is small, so they can reach the hospital anytime. So travel advice, most of the time, it has never been an issue. But yeah, we have a dedicated nurse who actually gives them a call to check the next day to figure out how they are doing. And in terms of anticoagulation, we also have like a checklist when they should restart and what are the things they need to watch out for. Yeah.
Thanks, Ravi. I think one thing is we should do, at least in this particular patient, is whenever we see somebody like this, right, we have a great opportunity to educate them about other parts of their general health. And in this guy, smoking cessation is very important. And Anderson has a smoking cessation program that is actually free for patients. That was partly funded, that was actually funded by the lawsuits that happened against the cigarette companies or tobacco industry. So that's one thing to keep in mind. And the second one is he's young. Probably a good idea to send it to a high-risk clinic to see whether he belongs to the high-risk group. And lastly, every time we see somebody, you should tell them one thing that makes a big difference in colon cancer prevention, that is exercise. So, and lastly, because of COVID, most of us are not able to have our family, patients' families with us. And what I've been doing is before I start the procedure, I actually call the family member using my cell phone, explaining to them what we're going to do. And after the procedure, I call the family member again and explain to them the result. And it's good to have the patients have access to your cell number, especially if you're doing high-risk polyp resections, so that if a patient has a problem, they're not stuck in the hospital system of trying to navigate to reach to you. Most people don't bother you. I'll tell you that. If they have a problem, if they bleed, you want to know first so that you can take proactive steps. So I give my cell number to my patients. Thank you.
One more question. What would be the surveillance interval you recommend in this case?
So one thing as I do is this is my practice, whenever I do a large polyp resection, I basically tell the patient that I'm going to resect the polyp and come out. I will not be able to look at your colon. You already had your exam, but my goal is to take care of this polyp and come out. And irrespective of whether I had an en bloc resection, in this case, an en bloc resection, and for sure, if there's a piecemeal resection, you want to go back and check it at 6 months. And even if there's an en bloc resection, I go back and check to make sure that there's no other lesion. And what I've seen is by doing that, I've seen a lot of patients have multiple lesions left behind by the referring physician. Maybe he was hoping that I will remove that lesion and other lesions. And the reason I don't look for other lesions is after you remove the polyp, you have to bring the polyp out. You already spent a lot of time, and going back and checking, you put the patient at a higher risk. So,
exactly.
So Joanne has asked about, we'll go with this MRI compatibility of the clips. I think Joseph has sent out. Joseph, you want to talk about that? And then we'll wrap it up.
Yeah, sure. Hi, everyone. Yeah, so there's a patient sheet or a PDF link I put in the chat that I've been sort of giving to my patients, especially if I did do clips. But it's MRI conditional. I tell them it's safe, but under certain settings. So before discharge, I print this out. I put the location of the clips and how many I placed, and on the day. So I say, if your treatment team needs to do an MRI, just bring this to the radiologist. But I certainly would love to hear if there's any other suggestions or anything specific from Boston or any other companies that use these clips.
And Dr. Zong, I'm happy to report that next month or two, those are going to be packaged. They're going to be included within the package. So that's soon to come. Been long overdue.
So say it again, what is going to be included? An educational pamphlet or what?
Yeah, just a little insert card on the MRI conditionality.
That's
for
nice.
the, just to be able to place within the patient record.
So what I see Laura putting in saying that they're MRI conditional for both 1.5 and 3 Tesla. Is that right?
3 Tesla is what I'm familiar with for the resolution clips.
Up to 3
Yes.
Tesla, it is conditional.
Yes, that is correct, Dr. Raju. I'm looking at the info that Tom sent it to me a while ago, and that's what it says on the outside of the clips.
Yeah. So one thing is I wanted to. Yeah, Joseph, go ahead.
Oh, sure. No, I was just wondering, are these inserts are we routinely giving these to our patients after endoscopy at our institution, or
I don't think the inserts are there yet, based on what Tom said, but I think it's an excellent point that you raised, Joseph.
Standalone card, but they'll be included in the next couple of months.
We don't have it on the Boston Scientific or Cook, but the pamphlet is included on the Microtech clips.
Okay, all right. All
So
right.
it's good for our nurses to know that, that to be looking at those packets and not throw away the packet. There's an insert in there, or will be soon, that we
Right.
can give to the patient. So the endoscopy nurses, please be aware that this is something that will be coming, and good information for the patient. Good to hand over to the recovery room nurse.
All right. Thank you, everybody. Thank you.
Thanks, everyone.
Thank you.
Jeffrey, Sylvia,
you.
Ravi, Roy,
Thank you.
Tom, and
Joseph, Stephanie,
Joseph.
Joanne.
thank you so much.
Yeah, thank you, Dr. Raju. Thank you, Dr.
Thank you.
T.
all.
Bye.
Bye-bye.